There's a video of me being assisted walking into the back doors at Emory. And that's absolutely the last thing I remember until I woke a few days after my 44th birthday in late September, 3.5 weeks later. I'm an infectious diseases specialist. I've been living and working in Kampala, Uganda for the past 6 years at a place called the Infectious Diseases Institute. And my work is focused on how to develop clinical reasoning and decision-making skills in African clinicians, typically in the area of HIV and TB and malaria. Don't let me fool you, I don't have years of Ebola experience, although we've had a number of outbreaks of Ebola and Marburg in Uganda in the past years. My first small experience was with a Marburg outbreak a few years before. But I was hearing of a tragedy unfolding in West Africa. In July, made contact with Doctors Without Borders and with the World Health Organization and with an old friend and colleague, Shevin Jacob, who had been on the ground. And a week later, I got a call from Shevin. He was in Kenema, Sierra Leone, and suddenly my abstract ideas about going to help, I did think that my training fit the needs, suddenly came to coalescence, and within a week I was on the ground in Sierra Leone. I joined a small group of technical experts providing assistance to a group of national staff at the Kenema General Hospital. Now, Kenema had a Lassa fever infrastructure. People had been studying Lassa fever and other hemorrhagic fever for years. It became a natural place to care for the first Ebola patients who showed up at Kenema. It wasn't a typical ETU in that Doctors Without Borders knows how to do this well. They can drop an ETU in the middle of an open field in a sense, and it's self-contained and has everything you need. And Kenema had to evolve in a national government infrastructure in real time to real needs. As the virus crossed the border from Guinea, remember it crossed over initially from Gekadu. It really disregarded international borders, and it really began to flex and it began to roar. And it first roared in Kayahoun and in Kenema. So in those early months, after the first cases at the end of May, in June and July, the virus slowly began to roar. Always with an eye towards the capital in Freetown to the west, but it began really around Kenema and Kayahoun. And so the ETU there shifted in real time from week to week in dealing with these unexpected volume of cases. I joined John Shefflin from Tulane, who had worked on Lassa fever for years. I joined Susan McClellan, also from Tulane, and my friend and colleague, Shevin Jacob. And we were the technical team providing assistance at the Ebola treatment unit there. Now, it was difficult. We had, at any one time, 70 or 80 or 90 patients on a given day, some of those in the suspect ward, some of them in the confirmed ward. But our small team of 4 or 5 clinicians struggled, as did a group of national healthcare workers, Sierra Leonean nurses and hygienists and laboratory technicians who in general were understandably anxious. They had seen many of their colleagues and family members and friends die within those walls. You can imagine how difficult it was on a daily basis to go back in quietly and resolutely and with very little fanfare. So I must say, as people talk with glowing language about my time in Kenema, I was only there for a short time. And those national staff, doctors, nurses, lab techs, clinicians, have been going into those care environments for a long time and are continuing to do it today. And they're doing it very quietly and with very little fanfare, and have really displayed an uncommon heroism as they do that I personally will never forget, and that we need to consider as we learn our long-term lessons from this outbreak. We owe it to their memory to learn them well. So it was a difficult time taking care of patients. I thought I was prepared. I've taken care of infectious disease patients in Africa for a number of years. I've taken care of patients after traumatic situations like the World Cup bombings in 2010, but nothing prepared me for the realities of taking care of patients in that unit. I've often said that this is a villain of a virus. Not only does it kill at very high rates, it does so at a pace and with an aggression that absolutely robs patients of their dignity. So while we were technically prepared to provide care, nothing prepared us to deal with the devastation we were seeing in individuals and in communities and in families. And so in that very grim setting, people died, sometimes 6, sometimes 8, sometimes more a day. And people survived. And we don't talk about them nearly enough. What made the difference, we're still trying to understand, but it was a very difficult time to take care of patients. I suppose there's an element of that risk that you consider before you decide to go. I will say that there are many people who have considered that risk and have gone in the past, presently, and will do in the future. So, of course, you have to carefully consider that risk, and of course, as you move into the isolation wards behind the curtain, in a sense, especially the first few times you do it in personal protective equipment, it's difficult, and it's a shift from how we typically practice medicine. In addition to loving the science and the care of patients clinically, I love the interaction between a physician and a patient at the bedside. And you find that in the spacesuit of PPE, that's very, very much changed, where your patients can only really see you by your eyes or something that you perhaps have written on your PPE to identify you. I remember a time when outside of PPE I wandered around to an area of the unit in which we had convalescing survivors. So their tests were still positive. We were waiting for them to clear, but they were well enough to come and sit outside in a sunny area. And there was a hill where you could look over the fence into this area. And I remember standing there expecting them to react, seeing me there and realizing they had no idea who I was. Until I opened my voice and these survivors suddenly said, Dr. Ian, you're so young." It was a very sort of poignant look at how the typical interaction between a patient and a physician at the bedside is changed by being in PPE. Both personally, it's difficult to take care of patients in PPE. It requires that you pay attention, to take your own pulse, to be aware of how your own body temperature is running, but then at the same time to be constantly aware of your own safety as you interact with patients. And of course, we're interacting with body fluids all the time. It's very important to make sure that your own safety is above even your patient's safety. And that doesn't always fit with how we typically think as clinicians, but very important. So it was a transition to be able to take care of patients in that setting, and I was subsequently to find that it was very interesting to shift suddenly to the inside of the bed when I woke up much later and found that the clinicians taking care of me were in a different type of PPE, but still I could only see their eyes, and it's a really interesting space. I've started to talk about this space as a dual citizenship of sorts. I was born in Zimbabwe. I'm a naturalized U.S. citizen, but I don't mean a political citizenship. I mean one that holds in tension these dual roles that I have, these bilingual roles as an Ebola doctor and Ebola patient. And it's interesting in many ways. So to get back to Kenema, we cared for too many patients, lots of patients, and patients that were in general very, very sick. There are two types of patients on the wards. If you're clear-headed and lucid, you're lonely and terrified. And as was often the case, if you were developing what we started to call a vacant encephalopathy, so confusion and delirium with bloodshot eyes, patients got sicker and sicker. That was often a predictor of their death to come down the road. So it was very difficult to care for very sick patients. I will say, though, we've spent a lot of time talking in the past year about magic bullets that might help us better deal with this virus. And for those of us who spent some time on the ground, I think there's a common soapbox among us in which we're really convinced, given that A very important driver of the disease that we see in patients is the very early gastrointestinal losses that we see. So severe diarrhea and vomiting. That sets patients up to develop severe dehydration. And that severe dehydration is a very proximal upstream driver of a lot of downstream organ dysfunction and mortality. Now, preventing and treating severe dehydration is not rocket science, right? We know how to do that. To patients who can drink, you give them lots of oral rehydration solution. And to most patients, especially the sick patients, you give them aggressive intravenous volume repletion with appropriate fluids. That's definitely not rocket science. We've known how to do that for years, right? In patients who have electrolyte abnormalities, which are very common. For example, most patients have a profound total body depletion of potassium. We know how to give potassium. We just need to be able to check it and to be able to give it. These aspects of clinical care are not rocket science. They're not complicated. In one sense, they're simple, but they're not easy. They are going to require someone being at the bedside, paying attention in real time to changing physiology. This is a fundamental principle of critical care. And in order to do that, that requires bedside presence, probably not of infectious disease doctors or even critical care doctors. I mean well-trained nurses who are able to be at the bedside for long periods of time. That's difficult in PPE. That's difficult when many of the nurses have seen many of their colleagues and their patients die in the same ward. So there is a principle here. While we do need to look for new treatments, many of us believe that we can get more bang for our buck from providing aggressive supportive care to these patients. And by supportive care, I don't mean hand-holding. I mean the aggressive use of intravenous fluids, of electrolyte replacement, of antibiotics and treating other infections. And so a vaccine will change the game, but I think what we really need to do, Paul Farmer talks about the fact that Ebola has never really collided with modern medicine. In fact, it's collided in a few of these evacuated survivors in new ways. Other than that, it's really only collided with mice or non-human primates and macaques, which is important. But that collision needs to occur on a more regular basis. And it needs to occur by figuring out how we can train local African staff, nurses, healthcare workers, to be able to be at the bedside in these settings for longer periods of time. That means not just an international response. We have to think about developing local African available talent. Well, I think there's a confluence of things. Dan Bausch has written about the ecology and the things that predisposed this melting pot of sorts for the scope of this outbreak. And remember, it could have been much worse, right? Sierra Leone, for example, is a country of 6 million. This virus was almost unleashed in a country of 170 million in Nigeria. There were many, many rubber plantation workers who went back to India and China and Southeast Asia. So in many ways, we've dodged a bullet in that regard. This doesn't minimize the scope of the suffering that this outbreak has shown us. But certainly there was a confluence of factors, years of civil war, very, very poor public health capacity after those years, porous borders, the confluence of people with ecological niches in which these animals are found. So there are many factors that produced this propensity for this to happen. But it will happen again. It may not be a filovirus, but it'll be perhaps a respiratory virus like MERS coronavirus or something that we haven't identified yet. And so we need to really make sure as we crunch the calculus from this outbreak that we don't forget about paying attention to the staff as one of our important long-term lessons. You know, we get shocked, I think, sometimes by the statistics, and they can be overwhelming and somewhat abstract. For example, 500 healthcare workers have died in West Africa during this outbreak. Let me put some flesh and bone on one of those. I am one of those, but let me tell you about a dear woman, a dear friend of mine. Her name is Nancy Yoko. It's important that you actually hear her name, Nancy Yoko. She was our head nurse, and as the lead clinician at the unit, I came to depend upon her for much of our daily work and the way that the unit ran. She was a very kind woman. She was a tough woman. And she was the glue that kept together a group of understandably anxious national healthcare workers at that hospital. And she was a remarkable woman. She was exhausted. And as September turned, she came to us with fever, and we admitted her to our suspect unit, and then transferred her to the confirmed unit when her PCR was positive, and then cared for her as she deteriorated, and then mourned for her with our whole community as she died. So we don't talk enough about this uncommon heroism that was displayed and is being displayed today over this time. But she was one of many healthcare workers who have been doing this for months and months, and have been doing this with no fanfare, and have been doing this very resolutely. And one of the reasons that it's important to me that we crunch that calculus well is that we owe it to their memory to not get caught flat-footed again. During my time as lead clinician, other things happened. You may have heard about a young British nurse named Will Pooley. Will was a young nurse who had been providing voluntary palliative care in Freetown. When he heard about the epidemic, instead of fleeing, as so many were, he took his single backpack and walked directly into the center of it in Kenema. And when I arrived there, he was doing yeoman's work, keeping that group of nurses together as well. And on my first day as the lead clinician, he came to me with sore throat and with fever, and we drew his blood. And later that night, I was called out of the wards, and eventually, in full personal protective equipment, found him in his room and delivered to him his diagnosis. Now, both of us had seen the natural history of this infection play out many, many times, so we didn't need many words. And one of my first sort of acts then, on the phone with the British government and with the Royal Air Force, was to organize his evacuation. And so there's an odd picture in national media of Will in a bubble taken by Susan McClellan, in a bubble on the Lungi airfield, being put into a large Royal Air Force jet headed toward the Royal Free Hospital. And we had several other similar evacuations occur during my time there. In fact, after one of them, I turned to the medical team on that jet and said to them, "This is happening too much. I don't want to see you guys again." I'm sort of making a wry joke. And it turns out that I would see them again. So on Saturday, September 6th, I developed fever and muscle aches and a headache. I self-isolated in my hotel room. I was given a Vacutainer and drew my own sample, and then handed it back to them, and then sat down to wait. And early the next morning, I received a call from a dear CDC colleague of mine who was in tears with a positive PCR. And after discussions with the World Health Organization about where I might go, initially the options were Geneva or London or the US. We made some decisions, and then I first called my family. I didn't want to call them until I knew whether my diagnosis would be positive or not. And then sat down to wait. People often ask me during that time whether I was afraid. Of course I was afraid. I had seen the natural history of this illness play out many, many times. Had many, many patients die. We had times when I had 5 or 6 or 8 or more patients a day die. So I was well versed in the possible outcomes. Of course I was afraid. I'll tell you what I really was. I was overwhelmed with this immense relief that I could sleep. So in the next day or two, I spent a lot of time sleeping and waiting for the evacuation to get set up. And on the same tarmac, with the same jet and some of the same medical team, I had my first private jet ride, in a sense, as an Ebola patient. and was taken from the Lungi airfield in Sierra Leone to Emory Hospital, where on September 9th, there's actually a photo from one of the news helicopters looking down and saying, "We don't know who this man is, but he's a very large man." And there's a video of me being assisted walking into the back doors at Emory. And that's absolutely the last thing I remember until I woke a few days after my 44th birthday in late September, 3.5 weeks later. Obviously, it was very difficult for them to hear. I had been talking with them occasionally about what was happening in Kenema, so they knew it was a very difficult place, but everything becomes reality when they're talking to their son, right, or their brother. So initially, I suppose, in some way, this dual citizenship allowed me to take a very detached clinical view of my own case and perhaps avoid sitting in that very vulnerable and very helpless place that is being a patient, for good or for bad. I'm still trying to understand what was happening there, but I remember telling them on the phone that they could maintain their privacy. I had seen a lot of press frenzy around the first 2 patients that were transferred or medevaced, and I really wanted to make sure that they were able to be private and go through what they're about to go through with me, with their privacy intact, and I knew that the Emory doctors would respect that. And also, although I didn't expect at the time, people asked me as well, were you worried that you would die? Again, of course I'd seen lots of that, but in some way I didn't think about dying at that point. I just thought I would be fine. I would need some care and I would be fine. And obviously I had no idea what was coming down the road. So this is all secondhand. I was unconscious for most of this time. I know this from my doctors and my family and a very sobering read of my medical chart. When I first arrived at Emory, I was fairly well, at least. I was clear-headed. I was able to have conversations with CDC epidemiologists and my clinicians, but quickly in that first week that changed. I became delirious and confused. In one sense, the same sort of vacant encephalopathy that I was seeing in my patients in Kenema settled in my head. We don't do lumbar punctures because of the risk, but almost certainly Ebola was invading the brain. I developed very profound gastrointestinal symptoms. There were days where I had 8 to 10 liters of diarrhea a day, almost like cholera. I had pretty profound electrolyte imbalances, and as we would in Kenema, they were delivering large amounts of intravenous fluid to try and make sure that they could catch up with those things. I saw many patients in Kenema. Very few of them actually developed respiratory failure. In fact, we don't see that very commonly in Africa, this acute respiratory failure that we've seen in some of the medevac survivors. Why? Probably because we never catch up with the profound gastrointestinal losses and the volume depletion. But it turns out that if you catch up to those losses and you make people euvolemic, true volemic, especially in the context of Ebola causes what we call a cytokine storm, and you have very leaky blood vessels and capillaries. In that context, with volemia, there's a chance you might spill some of that fluid, in a sense, into your lung. This is an oversimplification, but on day 6 or 7 of my illness, I developed hypoxic acute respiratory failure, and sometime on that following weekend, I was intubated and was mechanically ventilated for the next 12 days. As that was going on, my serum creatinine, which is a reflection of your glomerular filtration rate, or how well your kidneys are working, was slowly heading up, and it peaked over 10. Probably this was a combination directly of viral invasion of the tubules in the kidney, as well as I had a large amount of muscle damage, and the myoglobin pigment in the muscle can damage your kidneys as well. But I developed acute kidney or acute renal failure. And for the next 3 weeks, I was put on a dialysis machine that did the work of my kidneys for me. My liver tests were sky high. I had a number of other medical issues happen. I developed atrial fibrillation with a rapid response, which in a sense is an old man's heart rhythm. But it was a very, very busy first 2 weeks. Again, I was unaware of all of this, but my family certainly suffered. And the Emory team did a wonderful job folding my family into my care. This is probably one of the Ebola treatment units in the world in which family members can look through a glass window and see their family member and even speak on microphones. I couldn't hear them. I was unconscious at the time, but they were a remarkable part of my recovery. If you had told me on day one that a week later I would develop multi-system organ failure, respiratory failure, brain failure, kidney failure, and asked me to predict my chances of survival, I would have predicted them close to zero. I'd seen so much disease in Kenema, it was a logical conclusion for me. Many, even experienced clinicians might have said that providing this degree of life support and critical care was perhaps futile and perhaps added to risk for healthcare workers. Some part of me might even have agreed a little bit with them. So as the Emory team was fighting tooth and nail for me when I couldn't fight for myself, and as they intubated me and mechanically ventilated me, and as they dialyzed me and supported my kidneys, they really changed the game. I talk sometimes about the fact that as they were doing that in that small SCDU room, they were walking on the moon. And there are some ways, and in some ways, they were going to walk on the moon again with me a few months later. Certainly there were some points in my care when my caretakers and my family worried that I would not recover. There was a time when they were having serious conversations about intubating, about my kidney disease. And even after that, when my respiratory status stabilized and it looked like my kidney numbers were going to improve, I had developed some very ominous neurologic signs, something we call disconjugate gaze. And suddenly I didn't need sedation anymore. And I had a prolonged period of unresponsiveness. So there was some concern that I wouldn't make a meaningful neurologic recovery for a time. This was extremely a difficult time for my parents and my caretakers, and one in which I'm still learning about how they embraced me. They filled the room with pictures from prior points in my life. They piped in pieces of music that I loved, the Adagio from Beethoven's Fifth Piano, which I absolutely love. And daily my mom read a poem that my uncle, his name is John Eppel, he's an academic and a poet and novelist in Bulawayo, Zimbabwe, where I grew up. And he had written a poem in early September that my mother read through the speaker as she asked one of the nurses in PPE to touch me, to sort of try and extend her contact to me. And so there's some remarkable aspects of that time that I was unaware of until much, much later. But certainly there were days in which my caretakers and my family worried that I wouldn't recover. So I did receive two experimental therapies. Emory had asked for emergency FDA indication for two therapies. I received the lipid-encapsulated RNA interfering molecule from Tecmira, TKM, and then in an odd full circle way, remember Will Pooley, the nurse that I had evacuated? He emerged from the Royal Free Hospital in London. He was given an emergency passport. Remember, they burn your things in Africa when you get Ebola. And realizing that he was my blood type, he was put on a plane, came to Atlanta, and within a few hours of coming off the plane, was giving plasma in the plasmapheresis unit, warm plasma that was immediately given to me. And I received 6 separate doses of Will's plasma, hopefully with some IgG antibodies that might affect the course of my disease. That's impossible to say unless we have really, really good randomized controlled trials. But it was amazing that just a month later, a healthy Will Pooley, or a getting healthy Will Pooley, was at my side at a time when I was completely unaware of it and very close to death. At that point, people asked me, well, what made the difference? How is it that you survived when probably you should have died? Even if you go back and look at some Kenema data that came from May and June in Kenema, one of my colleagues, John Shefflin, and a number of clinicians there, including authors who had died by the time this paper was published, have written about that early Kenema experience and looked at the outcomes that made a difference. And one of the things that clearly mattered was age. I was right on the border of being in the older age in which mortality was much higher. Another thing that clearly mattered was the amount of virus that you had. And my viral load, the amount of virus was in some ways many times higher than any of the other medevac survivors. I had a degree of organ dysfunction, this multi-system organ failure that was a very ominous predictor of death. And so in some ways the deck was stacked against me in that regard. Very recently I've become aware that you know, we wonder about how much your genetic background might contribute to mortality. And in a very interesting study done after the Gulu outbreak in 2000 and 2001, they took 77 survivors and looked at, it's called an HLA-B locus. It's a very important gene for immune function and many other things, actually, to put it simply. But they looked at this locus in 77 of these survivors and looked to see if any of the particular types of genes or the allele made a difference. And they actually found 2 that were really associated with non-fatal cases and 2 that were associated with fatal. And it turns out that one of my HLA-B genes is the one that was most strongly associated with survival. So perhaps in one way a gift from my mother and my father contributed to my own survival in this case, because everything else seemed to be stacked against me. I will say though that people ask me often, how do you feel about the fact that you were medevaced? And many of my patients and some of my colleagues and a few of my friends did not have that same access. Now, do I think every patient in West Africa should have been medevaced? Absolutely not. But I do think we need to think about how to bring some of the weight of modern medicine to bear and collide with Ebola, as Paul Farmer says, on the ground in West Africa. On one hand, I'm sure that I would have been dead in a week had I not been medevaced. And so I'm extremely grateful to the World Health Organization and to the State Department, and especially to my Emory clinicians. I received a very expert mercy in a way. And many of my patients and some of my colleagues and some of my friends did not have access to some part of that mercy as well. So in one sense I'm very grateful, and in the other sense I'm haunted by the fact that I was afforded something that they perhaps weren't. And it turns out that survivor's guilt, even if it's unwarranted, is a common theme in many of the West African survivors who have lost either all or many members of their family. They've lost colleagues, and sometimes it's a difficult thing, amidst the joy of survival, to sense all of that loss and wonder why you ended up different. So this is holding these 2 things in tension will be something that I'm just beginning to learn about, and I think we'll be learning about for years. But that reflects an inequity in global health that many of us have been thinking about for years and years, that are long-lived inequities. They're much broader than Ebola. But I think this outbreak, as we learn the long-term lessons, we really have to think about how we make sure that, again, I don't mean medevacing everyone, but I mean bringing modern medicine to bear on an infection in situ in West Africa. And so both are true. eventually, and this was true in Kenema as well, if you keep people alive long enough, their own immune systems will begin to work. And you begin to make some IgM and some IgG antibodies, and you begin to make T cells that recognize Ebola. And that was true of me. I developed very vigorous, adaptive immune responses, and eventually I cleared the virus. And I had virus everywhere. I had virus on my skin, I had virus in my endotracheal tube in the lungs, I had virus in my stool, and of course had virus in my blood, had virus in my urine. But eventually all of those cleared, and I was able to move to another room out of the isolation unit, and my caretakers and family were able to touch me for the first time just with a glove and not with a spacesuit. And after 40 days and 40 long nights, I emerged as an Ebola survivor. And this was remarkable. As I look back, I'm realizing how remarkable it was. At the time, I didn't have any sense of the gravitas of what I had been through and what my caretakers had done for me. I quickly learned over the next month. So as I emerged, I was 30 pounds lighter. My hair had fallen out. I was struggling with a very difficult proximal muscle weakness and with my balance, and was learning to walk again in many senses. But I was an Ebola survivor, and I went back home to Phoenix and began to get stronger. During that time, it quickly became apparent to me that not just because of a long hospital stay, but something else was awry here. My colleague Dan Bausch from Tulane and the WHO has written very poignantly about this very recently when he said, even when it's over, it's not over. And I began to develop the first clinical symptoms of what has been variably called a new post-Ebola syndrome of sorts. Now, this is not a new disease. We just are shining a light on it that we've never shone before in now 10 to 15,000 West African survivors. So during my convalescent period, I got invited to the White House and had a chance to see and meet the president and also some of the other survivors. And there are now 9 survivors in the U.S. 2 of the medevac patients have died. And in a sense, I joined this small, somewhat exclusive club, I suppose. But I quickly move sometimes to show a picture of one morning in Kenema where we discharged 9 survivors. The whole number we discharged in one morning. And you can see when those survivors emerge, this joy on their faces. Again, joy mitigated by a great deal of loss in almost all of them. But as they move out, many of them began to struggle with some of the same things I was. So what have I struggled with? The first thing has been a really profound fatigue, a really disabling fatigue. There are times in the evenings especially when I feel punch drunk and unable to keep my eyes open. It's something that I'm developing a new respect for. That comes with some odd sleep dysregulation. I will say that I've just returned from a month or two ago from some time in Liberia in which I had the opportunity to sit down with the Emory Eye team with over 100 survivors. And many of the things that I tell you now are exactly the same things they're talking about. It turns out that I'm not so different from 10 to 15,000 West African survivors. So the first thing has been a really profound fatigue. The second thing is I've struggled with some problems with my thinking. So short-term memory and word finding are things that have plagued me. I mask it well, but they're there. Many survivors, including me, are struggling with a great deal of joint and muscle pain. There is a story there that will be very interesting to unpack. But certainly in some ways, my joint disease at least is mimicking a rheumatologic syndrome. This is going to be very interesting to both to care for survivors, but needs to be understood as a new disease as well. Many survivors are struggling with headaches and some neurologic symptoms. I've developed some neuropathy in both of my feet, and then I'll talk a little bit more about the eye symptoms that survivors in West Africa and survivors on this side of the pond are experiencing. In addition to that, I've lost most of the hearing in my left ear and now have a very annoying high-pitched tinnitus that I think will be with me for the rest of my life. I lost a lot of weight, but I've gained it back very quickly on steroids and some other things. But clearly there's something that's not emerging as a new disease, but we're looking at it for the first time in such detail in all these survivors. It's probably not a good term actually to call it a post-Ebola syndrome, because there will probably be some heterogeneous spectrum of disease and severity. But certainly patients are struggling. It's not over when it's over. And that's true. You can imagine it's quite tragic in some ways for a survivor to go through a first hell as they have family members and are close to death themselves in the village, and then an even lonelier hell inside an ETU in West Africa, and then to emerge remarkably from that and to slowly realize that, my goodness, my life has changed. And so understanding this syndrome, and by that I mean really in a way that is driven by a need to provide patient care first, is going to be a very important part of these next few months. Let me perhaps focus a little bit more on the eye as we move forward. I was dealing with a lot of things, just trying to get stronger and learning to walk again and sort of reconnecting to life. I didn't pay very much attention to my eyes. In fact, it was some questions asked of Kenema survivors, some of them patients that I had taken care of. They were asked, what are you struggling with, after Ebola? And one of the surprising things was that 40% of them complained of problems with their eyes. That actually caused me, seeing that emerge from Kenema survivors, to start paying attention to my own eyes. And I realized that I was developing a little bit of burning in both eyes, some light sensitivity in both eyes, and then also I was struggling to see with my near vision. Instead of looking at my phone here, I had to hold it out here. That prompted my first meeting with Dr. Stephen Ye. He is an infectious uveitis specialist at the Emory Eye Center, and my infectious disease doctor, Jay Varkey, connected me to him. And in November, I went for a baseline eye exam. When I went, I was having very minimal symptoms, if any, and I met Steve, and it turns out that my eyes were seeing well. That's my visual acuity. I was at 20/15 in both eyes. The pressure in my eyes was good. Even as Steve looked in the front of my eye, the front of the eye is called the anterior chamber, and as he looked into the eye with what we call a slit lamp, he saw that the anterior chamber was deep and quiet. The language is really interesting to me in ophthalmology. The anterior chamber was deep and quiet. But as he looked through my dilated eyes into the back of my eye to the retina, he noticed some small hyperpigmented scars in both eyes. And in fact, it reminded him a little bit of some of the characteristics we see in patients who have West Nile virus infection of the back of the eye. But it looked like those were scars only. There wasn't too much inflammation. And at the time, we made a decision to watch this very carefully. And after that visit, I went home for a very poignant Thanksgiving visit. You can imagine that at my sickest, it was very difficult for my family. And my mom had long looked towards the Thanksgiving holiday as something to anchor our family, if we can just get to this point. These are times when I was on a ventilator and close to death. And so you can imagine how wonderful it was for all of us, and there's lots of family and lots of kids, to be together for a very, very poignant Thanksgiving. And then in early December, I developed left eye pain and nausea and a headache, and I noticed that the street lights at night had these bizarre halos around them. And I actually thought I'd made my first diagnosis of acute angle closure glaucoma. Late that night in the ophthalmology clinic, I saw Steve again with one of his residents, Jessica Shantha, and as he looked into my eye, he realized that the pressure in the eye was very, very high. Now, if you rub your eye, it should feel like a hard-boiled egg, and that's because there's an intraocular pressure somewhere between 10 and 20 millimeters of mercury, and my pressure was in the mid-40s. So the first things we did was to take some oral medicine and some drops to try and get that pressure down. But why was the pressure up? It wasn't acute angle closure glaucoma. As Steve looked, the angle was completely open through which the fluid in the eye is drained. And it became apparent over the next few days that I had what we call uveitis. The uvea is the inner and middle layers of the eye. To put it simply, I had inflammation of the uvea. Probably a better term would be I had ocular inflammation. And this made us scratch our heads. There was a little bit of signal in the mid-90s after a Kikwit outbreak that a few Ebola patients, after surviving Ebola and after clearing the virus, developed a mild eye disease, but called a uveitis as well. And that disease responded within a few weeks to topical agents only, and it was mild. It soon became apparent that my eye was a different animal. And over the next few days, the pain and the redness got worse. The examination as he looked into the eye with the slit lamp was getting worse. And we began to worry that maybe there's something else going on. I had been through 6 weeks of a hospital stay. Almost assuredly that made me a little bit immunocompromised. And Steve worried about the presence of the more likely viruses in the eye, herpes viruses, so CMV, or herpes simplex 1, or the varicella zoster virus. Of course, on the list was Ebola, but those patients in the mid-90s had an immune-mediated process, but this looked a bit different. And so I didn't expect to be spending a Sunday afternoon doing this when I left the hospital in October, but on a Sunday afternoon, Steve inserted a 30-gauge needle into the white of my eye and slid it over to the front, the anterior chamber, and took a very small amount of that aqueous humor fluid. I remember at the time turning to the team, our team in the room, and saying to them, listen, this is not going to be Ebola, but just in case it is, remember what it feels like to be right in the middle of a paradigm shift. And a few hours later, we had the rapid PCR test come back positive, and the next day, a test from the CDC came back that showed that the levels of virus in my eye were even higher than they ever had been at the highest time in my blood. And you can imagine this was quite a surprise. Though we prepared for this, we didn't expect Ebola to be present in the eye, and suddenly realizing after thinking that I was long done with this, that the virus had been squatting in a sense in my eye without paying rent for months was a very sort of personal affront. And that began a long and difficult next few weeks. I soon after that started, in addition to the topical drops, some high-dose oral steroids. This was in an attempt to tamp down the inflammation that Steve was seeing in the eye. And but soon after that, my visual acuity, which is how we talk about the accuracy, how the eye is seeing, started to get worse. So I went from 2015 to 2050 to 2080 to 2200, which is legally blind in the eye, to 21,000 to 22,000, and then I fell off the charts. And so by the end of the year, 3 weeks later, I could not see 2 fingers, 1 foot in front of my eye. All I could see, if you moved your hand enough, a faint sensation of light, and we call that hand motions only. So once this was unleashed in my eye, it had a very aggressive pace. There are some parallels with the acute infection as well, I suppose. Part of that was 2 very interesting things. Remember I said that my ocular pressure was very high. We treated that with drops and with oral medicines, and as it came down, it kept coming down. It normalized and dropped and dropped, and for a 9 or 10 day period, in the last part of December, the ocular pressure was less than 5, and often it was undetectable, or 1 or 2 millimeters of mercury. That is not sustainable for the eye, so the eye began to soften and to lose some of its shape and its architecture. This was very difficult, and it was occurring while I was on high-dose steroids. And then another strange thing happened. I woke up one day and realized that my typically blue eyes, the left eye was bright green. We call that heterochromia. We don't have time to go into the specifics, but this was a very unusual and somewhat bizarre finding in the eye. And this pushed us to think that perhaps the virus was doing a lot more damage, specifically related to the multiplication of the virus, and that it was affecting the epithelial cells of my iris, which gives us eye color, and the epithelial cells of the ciliary body, which is a small organ in the eye that produces that aqueous humor that makes the fluid. That's probably too much detail, but what I'm saying is that in a 3-week period, my eye went from 20/15 to hand motions only. I was completely blind. At the time, I was patched. My eye color changed in a very bizarre way, and I completely lost all the pressure in my eye. And we began to think about ways in which we could change the playing field in some way. And we thought about a number of options, but settled on one, antiviral options, and we were given an emergency FDA indication. And on Christmas Eve, I was admitted back to the same bed from which I left, and admitted in an eye patch, and I received 2 experimental treatments. I started the antiviral, and 5 days later, Steve felt comfortable about giving me some additional steroid treatment. So sometimes you can put a steroid injection directly into the eye, into the vitreous. This time he put it into the white of the eye and into the subtenon space, and you can still see that steroid injection here that in a sense is releasing a depot of steroid over the next months. So I received these 2 treatments, stayed in the hospital for 5 or 6 days, and on December 30th, right at the end of the year, my Emory team, I think they were recognizing how difficult this period was. It was a pretty dark December, and decided to send me home to Phoenix to spend some time with my family. On the last day, we checked my visual acuity, and despite those treatments, I was still off the charts and was at hand motions only. So it was an awkward trip back through several airports on the way to Phoenix. I've never faced any stigma because of Ebola, but I found that as I went through an airport with a Dread Pirate John Roberts patch on, that the children loved it, but that most adults seeing me limping through the airport with an eye patch didn't catch my eye. And it was a difficult, though again a very poignant New Year's Eve. 4 days after that, I developed a very bizarre, hectic fever syndrome. And as part of that care, ended up being medevaced back to Atlanta. It's a long story that I won't get into now, but during that hospitalization, remember I could see nothing through the eye. I noticed suddenly one day that I could see my brother sitting on the edge of the bed with a little more clarity. And it turns out that a lot of the inability to see was because the vitreous gel in the eye was becoming really densely full of inflammatory debris. And there's a picture that shows a clear eye and a very hazy vitreous gel. So that the ophthalmologist, as Steve looked into my eye, couldn't get back and see the back of my eye clearly. But from the other side, from that same retina, as Steve was trying to see, I was looking out through the same debris and the same haze and unable to see Steve. Suddenly, I wondered whether I could see my brother a little more clearly. And as the vitreous gel has detached from my retina, I found that I could use the muscles in my eye in a sense to move them around, and I could move that obstruction around. And I could find a particular place, I called it a little wormhole, through which I could actually see quite well. And slowly over time, that portal or wormhole over the last months has slowly increased in size. And though I'm not back to baseline completely, I really have had an unexpected and what I call a Lazarine return of the eye. The eye color, which we did not expect to come back to normal, has returned to normal as well. So it's hard to sort out what aspects of my treatment were involved in that, and we're going to be doing some work down the road to do that. But it was a remarkable recovery that in some ways paralleled my acute infection. I have had my vision tested and haven't had any difficulty with color vision, primarily probably because my retina was somewhat spared in this process. Now, I have those hyperpigmented scars in both eyes, so part of the reason I wanted experimental treatment is that I'm worried about my other eye as well. But despite having those scars, my retina is actually working quite well. I just couldn't see through that very dense haze in the media, in the vitreous gel. So I haven't had any difficulty with color vision or with other aspects of the vision that you might think about. My eye is not back to normal, but we're hoping that it will get there. I'm one of 10 to 15,000 Ebola survivors. Are we seeing some of the same things in West Africa? A month and a half ago, John Fankhauser, who's one of the heroes of this outbreak. In fact, he was related to patients number 1 and number 2 at his hospital. He was seeing Ebola survivors, and he's been thinking about survivors' care for a long time. He was seeing survivors come in with eye disease, or eye symptoms at least. And so 6 weeks ago, Steve Ye and I and Jessica Shantha and Brent Hayek took a small, nimble Emory eye team, and we looked at over 100 patients who were having eye disease. Let's put it simply, there are survivors after Ebola, even when it's supposed to be over, who are developing the same inflammatory eye disease. It's going to be a spectrum of disease. Some will be mild, but at least in some patients it will be severe and sight-threatening. Now, will all these patients have virus in their eye? Probably not. In some ways, the severity of my acute illness makes me an outlier. I don't think that will be a common finding, but at this point we don't know. There are monkeys, non-human primates, who have been studied for years with Ebola. And if you keep the monkeys alive a little bit longer with a research intervention, some of these experimental treatments, you find that they die later. And when they die later, they have what we call a delayed death phenotype. And you can find virus in different parts of their bodies that typically don't reveal virus. And one of those is the eye. In some ways, I might be quite like one of these delayed death macaques, in which we're seeing something quite unusual related to the severity of my acute illness, and typically we wouldn't have seen because a patient wouldn't have survived. But the eye is just one aspect of this spectrum of sequelae that we're seeing after Ebola in patients. Again, not a new disease, but this is really a first look at some of these complications. It's going to be very important to pay attention to other aspects as well. Initially, really to provide evaluation and care, and also to provide some training to the local African talent who are caring for these survivors, and then also to, very importantly, understand this disease as we're seeing it in a new way in such scope. So we need to think about what's going on in the joints of these survivors and how we might best provide treatment and care. We need to think about what's going on in the brains of these survivors. As I struggle with word finding and short-term memory and sometimes emotional scars coming out of that experience, you can imagine that the West African survivors will struggle a great deal more with some of these things. We need to think about how best to evaluate them and how to treat them. And there will be other things that come onto this list. So I think a really important part as we think about our long-term lessons from this outbreak is to make sure that we don't forget about this emerging problem in survivors. You know, and even before we talk about long-term lessons, I would say that this is not over. Dan Bausch has said again and again, you do not put out 99% of a fire. And the recent experience in Liberia, which remarkably now is down to 0 cases, I'd prefer not to call it Ebola-free, because Ebola-free means probably Ebola-free in all 3 countries, and this is a 3-country outbreak, and there are borders between these countries. In addition, there are hidden chains of transmission, and we're trying to sort of identify those and find them down. And finally, there are this very interesting idea that perhaps the virus can survive for a time, and at least a few survivors in other sites. And of course, one of those immune-privileged sites is the eye. The other one that's received a lot of attention recently is in the testes and in the semen. So we've got to be very, very vigilant as we move forward. It's remarkable, the fact that we're now dealing with just a few cases, less than 20 cases last week in all 3 countries, right? It's remarkable. But it's very, very true that it's 6 weeks from the last contact with the last case or the last death before you can say that a particular area is Ebola-free. And when West Africa is Ebola-free, perhaps we can declare that. But this is still going to take some time, and this last mile is a very difficult mile. We cannot too quickly turn away from this in the acute. So remember, this is not over. But as we get at least through the last mile of this, we need to start really thinking about the long-term lessons that are important here. I've argued already that we owe it to the Nancy Yokos in our midst, who are no longer in our midst actually, to really make sure we learn our lessons well. I think we need to remember with a sober mind that we may have dodged a bullet here. It could have been much, much worse. That doesn't take away from the loss that this outbreak has already provided. We need to remember that as we focus on system strengthening, there's a great need to focus on health system strengthening now. Paul Farmer talks about the need to focus on systems and space and stuff and then staff. As we do that, we often talk about space and stuff. But if we don't focus on the long-term slog of how to develop and train a group of local, African, well-trained, available, willing staff, we will be here again. And so we owe it to the memories of these healthcare workers and to many others to make sure we learn the long-term lesson well. And one of those long-term lessons is we got to think about how we enable a group of African local talent to be available for the next one. Finally, there's been a lot of talk recently about making sure that we pay attention to a big picture. Because we could do this quite easily with a 2 or 3 year Band-Aid. But there is a chance here. In a sense, the world's never looked at West Africa with this microscope before, and it may never look again. There is a chance here to do this in a much broader, more strategic fashion. It's often talked about like the Marshall Plan that was so important for reconstruction in post-World War II Europe. There is a chance to do something that resembles a Marshall Plan here that will have very long-term important implications, not just for health systems, but for economies, for civil societies, and for politics down the road, and for security down the road. And that security is a global security, and that economy is a global economy. You don't have to be a good Samaritan to recognize the importance of paying attention to these types of outbreaks and preventing them. You just need to be a good businessman. You can be pragmatic about it. And I think it's really important, as we do all of that, that we really focus on the staff moving forward. I'm often asked about how I was infected, and I've thought for long periods of time about that. There are 2 places that you can be infected. Well, we should say 3. One is inside PPE, one is outside PPE, and then in the important transition period where you don or you doff, take your PPE off. Inside PPE, I never had any very high risk exposures, although in that unit and given the number of patients we had, we were coming in contact with a lot of blood and a lot of diarrhea and a lot of vomitus, but there weren't any significant high-risk exposures that I can remember. There were no breaches in protocol as we doffed that I can point to. And outside of PPE, really for the whole time that I was in Sierra Leone, I never touched another human being. There's a no-touch policy. I find it quite odd as a person who wants to shake hands and wants to embrace. We never touch another human being. You just put your hand on your heart and you greet people that way. There was one time when I put a hand on the shoulder of a well nurse, just on her scrubs to comfort her for the loss of one of our other nurses, but really have no idea how I was infected with the virus. And that's actually been true of many of the healthcare worker infections. We're learning about that and studying that in great detail now. It'll be important to identify potential ways we can prevent or reduce this as it goes down the road. But the healthcare workers are remarkable heroes, the African healthcare workers particularly. They've been despite all of that risk. And that risk was not abstract to them. It was their colleagues, it was their patients, it was their families. They continue to go into those spaces very bravely and very heroically, I find. And that's something that we have lots of conversations about Ebola. But long before Ebola entered our national vernacular, these national staff were going into these care environments and doing it very humbly and very quietly, and I find that quite remarkable. My eye has not been retested because the pressure is low enough that it makes that procedure higher risk. But down the road we would consider ensuring that the virus has gone from the eye. Every indication is that it has. You should ask yourself, the eye is an immune privileged site, and immune privilege is a very interesting immunological playing field in a sense. Not only is the eye geographically segregated by the blood retinal barrier from my immune system, but the eye in itself is a locally immunosuppressed place through a number of very interesting mechanisms. So the eye has not been retested, but that probably made the eye a place that if the virus can get in, it's able to slowly and quietly replicate without setting off any alarm bells. So we need to really think about these immune privileged or sanctuary sites as we move forward in seeing survivors. So the eye is one that's received obviously a lot of attention. Recently, a case in Liberia has provoked some more attention to the possibility that another immune privileged organ, the testes, and semen persistence could be contributing to some transmission. We've known through only a few number of cases, but we've known for years that the virus can survive in semen out to 82 days by culture, and it can survive out to 101 days by PCR. Just a few cases, but to be honest, we haven't really known of the gravitas or the implications of that finding. Prior to a recent case, we haven't had any evidence that that's been involved in sexual transmission, and we haven't had much evidence that it's been involved with clinical pathology, as it was in my eye. That recent case is changing that, and this outbreak is changing that as well. So you need to stay tuned for important information that will be coming out about the semen as a potential longer-term sanctuary site in survivors. We should at least consider other immune-privileged sites. I don't think necessarily we'll be finding virus in these sites, but it may mean that these sites can contribute to some of the pathogenesis of the post-Ebola complaints. What do I mean by that? Many patients are having joint disease. I, for example, am struggling with my sacroiliac joints of my back. Cartilage is, in one sense, an immune-privileged site. So while I don't think that the joint will have active and replicating virus, it may be that the clearance of virus, so that there's dead virus around, nucleic acids, or antigen for some period of time. So we have to think about those organs. And the joints and the cartilage is a very interesting one. I have not yet had joint swelling enough to enable anyone taking fluid and looking. But it's certainly something that we should be thinking about down the road. I think an important message around the eye is, first of all, my tears and the outside of my eye, the conjunctiva, were completely negative. And that's with very, very, very high levels inside the eye. So my tears and the conjunctiva, this white area, was swabbed, and that's completely negative. There is not a risk of transmission of virus from survivors, even with this eye disease, from casual contact. It's very important that we frame the finding of virus in my eye in this context, because this cannot add to the stigma that many of the survivors are struggling with on the ground in West Africa. This finding has important public health implications. Eye care providers should absolutely avoid instrumentation of the eye or inserting needles into the eye under all circumstances. If it's absolutely required, that needs to be done in a very, very, very careful manner. thinking about the finding and its implications. And it obviously has implications for the type of eye disease that we see in survivors. For now, we should avoid doing cataract procedures, for example, for an unknown duration of time. Hopefully we'll be able to learn more about the disease and the incidence of not just the disease, but the presence of virus in the disease in order to define when it will be safe to do those procedures. But anyone doing eye care should avoid doing any instrumentation of the eyes related to that finding. One of the problems with this virus is that it has a mythical quality of sorts that we need to debunk. That has emerged because this virus has only emerged occasionally and in far-off places in Africa and in small villages in which it's burned itself out, but has never been a significant threat to other parts of the world. And this part of the world in which we sit is a very relevant one in that regard. So I think debunking some of those myths is very, very important. And one of the reasons we are going to learn a lot more from this outbreak. In one sense, the press played a very important role in increasing the amount of attention that was being paid to West Africa as patient number 1 and patient number 2 were med-evacuated. But also, there can be a negative role too, where conversations become about things that have no scientific basis. And it's really important that people become more familiar with this virus, and so it loses some of its myth. And for example, the idea that someone who doesn't have symptoms could transmit Ebola it's not just an idea. There's real science there. And so once people go through quarantine periods, they need to be able to return to their work and return to the space in which they work in terms of their relationships with colleagues and their relationships with family and friends. And so some of those myths are understandable. This is a terrifying disease. We're quick often to look for villains, but this virus is the villain, the only villain that we need here. And so it's understandable that people would have a lot of fear, particularly in West Africa, where if Ebola came into your village, it meant that half your village and many of your family might die. So it's understandable, but many of those myths sort of are related to some misinformation that I think can, perhaps not easily, but can be addressed. And we need to make sure on this side of the pond that we really address it with the average American. I've been on the ground in Uganda for 6 years, and my family and friends have known for most of my life I'd like to spend my medical time on the ground and some of my other time. So I don't think they were surprised, especially my family, that I would be going. In one sense, I think they were waiting, knowing that I was looking for a way to help and thought that my skill set met a need. So they weren't surprised. Of course, it created some anxiety and things that we talked through as a family. And these are important. These are part of any provider's decision to go and take care of patients there. There's an assumed risk there, and we need to keep understanding what that risk is and how to prepare for that risk. But there are many, many people who have assumed that risk, knowing that their skill sets meet an immense and sometimes a tragic need, and have gone and done that. And many who've been doing it much longer than I was in Kenema, and will be doing it for much longer than after I left Kenema. So I had some reactions from friends who asked me why I would do that and put myself in that position. And I suppose if we all felt the same, then no one would go and take care of patients. So there are a number of people who have been doing this long before I went and long after I went. Many, many thousands of people who are assuming that risk. We can do it and we can learn about it. We can do it more safely as we move forward, but there will always be a need for people to step into these care environments because of tragedies that unfold in settings like these. And people often ask me, surely you wouldn't go do it again? And that's a very difficult question to answer. I would never script this as an outcome. But I can't tell you what a privilege it felt to be on the ground in that particular place and in that particular time with that particular group of people. Those national staff and a few of my international colleagues. It was remarkable to be part of a very grim and tragic drama, but it was remarkable to be part of that for a short while. And I always consider the opportunity to be on the ground that the World Health Organization gave me something that will be a watershed moment in my life long before I get sick. I'm not a policymaker, nor am I a global health expert. I'm a clinician, so the bedside is my sort of sacred space, but I've been able to sort of see this in action before and after my infection, and there's been a great deal of cooperation and communication that's occurred between all three countries. Some of that's mediated by third parties, of course, but it's been a very important part of a three-country response in this epidemic. And we need to think about how we set the stage for that type of cooperation to continue to occur again. I found it very amazing how very quickly people came together and became a functional unit. Not just my international colleagues on the WHO team, but also as we interacted with the Sierra Leone national staff. And I think that happened by sheer necessity. In a sense, coming to work in an Ebola treatment unit, selected out for the kind of people who had some degree of flexibility and commitment to the work that had to be done. And it wasn't an option not to work in that manner. The minute that became an issue, your team fell apart and people were dying. And so I think everyone felt the weight of the tragedy that was at hand, of the importance of responding to it and changing that if we could, even in small ways, and of doing that together, and they did it. I think we're learning more and more that this global community is a small neighborhood. One of the most important things is for us to begin to think about the world as a small neighborhood. In a few hours, somebody who's incubating an infectious disease but asymptomatic can be on the ground in New York City, for example. That possibility has changed in the past 20 to 30 years. So the chance that something can be on our doorstep very quickly is very, very real. What does that mean? That means that in the rest of the world, we need to enable countries, really driven by their desire to get help, but we need to enable nations that are in places that are at particular risk to develop strong public health care systems. Those strong healthcare systems should include systems to detect, so surveillance of infections that are emerging, of ways to detect new infections that are emerging. But we certainly do need somebody thinking about the whole. And there's some very important discussions happening about how we globally can come together to make sure that we detect these infections early, that we contain them early, and that we have a group in general, best to be local talent, who can respond early. So there have been people thinking about those things for many years. This outbreak, an important unintended consequence has been that we really are thinking about them with an urgency now that will be very important to what takes shape down the road. In regards to how people are responding on the ground, Kenema is one of these places that's been through a very devastating year and a half that has not just affected and decimated their healthcare workers and their hospitals, but it's decimated civil society and their economy and many other very important aspects of health, including some gains that have been made in the past 10 years, have fallen apart in regards to HIV or malaria or maternal and child health. So everybody, I think, on the ground, Ebola survivor or not, is thinking about how we just reconnect to regular life and emerging from this process. That's difficult. In some ways, many people are shell-shocked, wondering how they're going to do that, and they're going to need some help. Not just physical help, but some long-term help with how to think through what happened and think through their losses. And in general, I think there's going to be an immense relief and an immense joy and an immense excitement. Again, not making or mitigating or reducing the weight of all of those losses, but there will be a remarkable joy that explodes when finally Sierra Leone and Guinea and Liberia are Ebola-free and this is finally over. The things that some of these survivors have been through and the people that are connected to them are unimaginable. Unimaginable. A good friend of mine, Dauda Fulla, is one of my patients. There's a picture that I have of Dauda holding his survivor certificate, and he's beaming. He's very happy to emerge from that very dark place. But he's beaming, also absorbing a great deal of loss. His father, who was a laboratory technician at Kanema, died. And then his stepmother died. And then his grandmother died. And then his 2-year-old sister died, and then another sibling died. So as Dauda Fulla emerges from an Ebola treatment unit, he's emerging in a sense as the new man in his family who takes care of the remaining members of his family, having lost half his family. What a difficult space to come into. So there is certainly a new norm in these survivors and in those who are connected to them, and helping them reinsert themselves into what will be a different life. My life has changed, their lives have changed, will be very important for the people who can be on the ground. Dauda has just finished or is on his way to finishing his own training as a laboratory technician, which is apropos given the fact that his father was one of the healthcare workers who died in Kanema. I don't know the details of what's going on the ground, although I will be learning those details very quickly. But I know there are survivors networks that are being set up in Liberia and in Guinea and in Sierra Leone, including a very mature group of survivors in Kanema. So addressing their physical needs and their emotional and psychological and financial and work-related needs is a huge need, but people are thinking about that and addressing that. There is a World Health Association extended survivors network that we hope will link many of the survivors in all 3 countries, and will also link the opportunity to evaluate them, to provide the kind of care that they need, and to understand the disease that they're having. I don't think, at least when I was there in August, that collision has occurred yet. Now, a very important part of this outbreak will be attention paid to how we bring elements of modern medicine to intersect with Ebola on the ground or other emerging infections. So as I said earlier, I don't think that means everyone gets medevac. That can't be what it means. But it does mean we begin thinking about how to take care of acute, critically ill patients in Africa. What is the role of intensive care units of a sort in particular places in these countries? How do we make sure that we have well-trained staff who can pay attention to changing patient physiology at the bedside in real time and are able to do those things and have the necessary equipment to do those things? Much of that doesn't require Swan-Ganz catheters and fancy monitoring, but there is an element of critical care that we can provide on the ground, and we got to think about how to do that well. When I was there, we weren't yet able to do that. There were just a few of us, and you can imagine there's a lot of difficulties intrinsic to taking care of Ebola patients that you don't even think about. For example, how do I put a stethoscope into my ears when I'm trying to cover every bit of my body? How do I take blood pressures with that? many, many basic elements of care that we were unable to do. And there's been a great deal of very important attention paid to that during this outbreak. In one sense, there are two goals for an ETU. One goal is to isolate patients and therefore protect the community. So you take someone who's infected, isolate them in an ETU, and you prevent infection from spreading in the community. That's a very important goal. A second goal, though, is once they're in the ETU to affect the disease, to save lives, to prevent morbidity. And often the latter has lagged behind the former over the last 30 years of Ebola or Marburg outbreaks. This outbreak is changing that. So paying attention to what we can do safely and what we can do more effectively in an African ETU setting has become something that's on people's agendas, which even as a start is quite remarkable. And things have been changing greatly even over the months that I've been in the U.S. since I got sick. So there are people thinking about delivering critical care on the ground in ETUs and taking steps towards that and doing it. So again, you'd never script this outbreak, never, but it's going to change the game. So it's important as we do that the long-term things we need to learn, we're learning well and beginning to move towards this infection colliding not just with some mice and some non-human primates. That's very, very important that they do, and not just with a few Ian Croziers, but with a lot of Nancy Yokos on the ground. Almost all of my patients impacted what I learned about the disease and its pathogenesis and its natural history in humans. I'm not an Ebola doctor by trade. I have a little bit of experience with the Marburg virus a couple of years ago, but don't let me fool you. I was new to this, but I very quickly gained some savvy, and so you don't learn about anything until you really learn about it in patients, right? Where a textbook sort of unpacks itself in a patient on the bedside. And so I think I'm so grateful, and to many of them who have died, for just the ability to intersect with their care. There are a couple that have taught me about many other things as well. Let me tell you about three brothers I will never forget. Victor, his younger brother Sheku, and his younger brother Ibrahim. I met Victor one night. He was lying on a mattress, unresponsive, severely dehydrated. He was lying in pools of his own vomit and his own diarrhea. And his two younger brothers were sitting next to him in the same pools, wide-eyed and terrified, but refusing to leave his side. They had lost their mother and I think some other siblings. Their father was not around. And I remember that night struggling to get an IV into Victor, thinking that I wouldn't see him in the morning. And as I came in the next morning, he was still there. And over the next few days, he pulled back from the edge of his own abyss, and he got stronger. And as he emerged and his younger brothers got sick, he became an 11-year-old father and mother to his younger brothers. They had an absent father and their mother had died. And I think they had lost siblings as well. One of the saddest things when I was forced to leave Kenema was that I didn't have a chance to wrap my arms around these boys outside of PPE. Much later, someone sent me a picture of them with a thumbs up and like typical African boys, grinning, happy to be out of the unit in fresh clothes. And there's one picture of Victor with his arms around his younger brothers, walking away from the camera in fresh clothes. And Ebola survivors, and in my mind, no doubt because they had each other. So there were many examples like that, where really remarkable things happened. You know, most patients enter the unit already having lost siblings and wives or husband and parents. And in that very, very grim setting, we started to see some pretty remarkable things happen. So parents who had lost all their children began to care for children who had lost their parents and their siblings. And these children lived who would have otherwise starved, and it was a strange foster care of sorts that was playing out in those environments. And I'm not sure I could have sustained work on the ground there without these little cracks of joy that sort of pushed their way into this dark place. And it was nothing if not a very dark place. And we saw some really remarkable human stories play out. People don't hear about those, but they did again and again as people struggled and did what they needed to survive. And parents, fresh from the death of their children, cared for children who had just lost their parents. And that happened remarkably. Unlike much of the world, I speak really only one language, and I don't even speak that language well. So I'm not sure whether my word-finding difficulty would translate into other languages. It's a very interesting idea. I will say that when I first woke up in the unit and was struggling to put the dots together in a fog after 3 weeks of unconsciousness, I really struggled with, we call it an expressive aphasia, and struggled with my balance eventually too. And there's some evidence on an MRI done months and months later that I really had a severe hemorrhagic encephalitis that has left me with hemorrhagic strokes in a sense. And I really have a new respect for this idea of the neuroplasticity of the brain. When I trained, we thought that once you had a dense stroke, your brain couldn't rewire itself. And that's changed a great deal in the past 10 years, in which we now think that the brain is a very plastic organ, even into your 80s. And have a new and an intimate and a remarkable sort of appreciation for that, because there certainly has been a lot of compensation and rewiring, given what I see on my MRI that my brain has done. Although there are times when I'm anxious or when I develop a fever that those sort of compensatory mechanisms fall apart. And probably that's something that I'll struggle with, I think, for the rest of my life. But it's remarkable how flexible and adaptable to change our brains are. We probably need to think about that as we think about our own health much more often. I suppose immediately I'll say being glad to be alive. I really was afforded an expert mercy in so many ways from so many people. And the fact that I'm sitting here talking clearly with you and seeing clearly through both eyes is really remarkable. I'm learning about the gift it is to, on a regular basis, be reminded how good it is to be alive. In the short term, I'd like to get back to West Africa as soon as possible. I obviously have an important and a poignant connection to many of the survivors there. I know that already from a recent experience in Liberia, and I'd like to be engaged in helping make sure that their care and evaluation and understanding this disease proceeds, even if it's just a small way that I can help, proceeds in a careful and a thoughtful and a scientific way. In the longer term, I'm not sure. This is going to be a watershed moment for my life. I'd love to return to Africa in the long term. I'd love to do that. For me, taking the best of academic medicine and unpacking it at an African bedside with African doctors and students is Camelot. So I'd like to figure out how I can do that down the road. But in the long term, I really want to get back in situ on the ground. We have a moral obligation to the memory of more than 500 healthcare workers and over 11,000 West Africans who have died during this outbreak, to make sure that we consider the long-term lessons we need to relearn or learn for the first time as we emerge. As we do that, a crucial aspect is thinking about how best we develop a group of African, so local healthcare workers who are well trained so talented, who are available and willing to turn into this when it happens again. That's much broader than Africa, but I think that would be my final leave.